coming and joining our very first Australian Sickle Cell conference here in Australia. Really appreciate it. And we are like a day and a half into this conference. So we've had so many speakers, so much current information from around Australia as well as around the world. It's very encouraging. So with all the information out there, so I'm looking forward to listening to you, Katie, to inform us mostly. So the conference so far has been quite informative with lots of information, current information from around the world. We are just waiting on Kate to join us, so I just thought we'd talk about that rather than it just sort of being a bit of silence. I have, over the years, seen a lot of progress with sickle cell disease around the world, and now with this conference, it's showcasing the progress that we're having here in Australia. It still needs a little bit of work, but I think, and I'm feeling confident now, more confident now that there are more healthcare professionals out there that are actually taking on board what's happening in Australia with all the migration coming in here, and you know, the information about sickle cell disease. They're actually knowing what's going on.
Hi everyone, thanks for hanging in there while we got all hooked up. I think the problem was, my pseudonym and not knowing who I was. So sorry about that. So let's kick off. So I'm going to talk a little bit today more generally about rare disease and some of the challenges patients and families have in navigating the Australian health system. So I'm just going to give a really quick little background about our organisation. And for me, I'm a researcher and also a telehealth nurse in rare, genetic and complex care. And that's the side of my work that I'll be talking about today. So CCDR, we have a vision to create a more person-centric health sector, and we do that in a few ways by providing a platform for patients and families to talk about their experience so we can use that as evidence for advocacy. We connect patient organisations together to strengthen that part of the health system. And we also test different ways for community-based healthcare. This is the part that I'm really going to focus on today. So we work in 18 countries across the world. I'll talk about the work we're doing in Australia today, which aligns largely with the National Patient Organisation Network program and the PEAK program, as well as patient pathways. So in Australia, CCDR hosts the Patient Organisation Network, and it's Australia's professional body for patient organisations. We have 135 organisation members, but a large majority of those represent rare genetic complex conditions. So our role is as a secretariat to look at what are the issues that patient groups are experiencing, and how can we use our skills and resources to help fill those gaps. So one thing we've done just recently is ask the rare disease organisations in our network, what are the things that you're really struggling with as an organisation? So some of the things they continue to struggle with are using evidence for advocacy. So how can we collect evidence so that we can have strong advocacy platforms? Some of that really practical help in having project officers and research support to help them either develop programs or develop information sheets and all of those things that you need to do as a patient organisation. Also having a telehealth nurse for their patients to call that has expertise in their specific disease, and helping their staff and volunteers to understand how the health system works. And that's really important, particularly in rare disease, where a lot of the staff come from a volunteer or might come from a different background. It might be a parent or a carer who's taken on that job of leading a patient organisation. So what I'm going to focus on here is the Patient Pathways Telehealth Nurse Service. So this is a program that has been piloted over the last 2 years, where you have a specialist telehealth nurse that sits in the community in a patient organisation. So it's a little bit different from a helpline. Helplines are primarily information provision. They don't go too far in depth to the patient medical history. Patient pathways somewhere in the middle between a helpline and that formal case management. So formal case management where you might have a finite number of patients that you follow. Telehealth nurse in patient pathway helps set up a patient so that they can better use the health system, they can better navigate the health system that is around them. So we don't form a dependency, but rather we give patients the tools and the resources to be able to use the health system better. So from the pilot that we've done, the first analysis, first evaluation, we looked at, there were 1,245 people within the service, primarily from rare disease. And what we saw was when the patient and family came to the nurse, they had around 6 different questions or complaints or issues that they needed to discuss with the nurse. And a lot of the most common things were around fatigue, mental health and pain management were some of the most common things that they were struggling to manage to find help and support. From that, each nurse across those 12,000 patients conducted 7 different interventions. So if you can imagine, that's 7 different interventions that may not have happened if those patients and families hadn't been able to contact a central telehealth nurse. Something that's really important, I think, to highlight is the value of being able to connect people and increase awareness of clinical trials, which is incredibly important, but also quite difficult in rare disease where there aren't always many clinical trials. But what the nurses do, and they do a great job at, is just raising awareness that if, what clinical trials are, and if there is one that comes up, to keep it on the radar of the patients. But also considering that clinical trials aren't just about treatment. There's supportive care, there's emotional support trials, exercise trials, there's all different types of clinical trials. And these can all become part of a patient's care plan. So what we've seen in terms of the different assessments that patients and interventions that the nurses do for the patients in rare disease in particular, doing a lot of symptom management. So working with the patient or the patient family to be able to understand what symptoms are presenting, either in themselves or their child, so that they can be on the front foot of when to go back for medical help, but also to help them see that baseline of progression. So sometimes it's hard if you're not recording things down to know when something's progressed. So this is a tool that the nurses work with the patients and families. We make sure that they receive a home status assessment. So this is really important too, particularly in rare disease, because you want to understand who's in the family unit and who else might need care and support. Often in rare disease, there might be multiple children with the condition, so we need to make sure everyone's looked after, as well as the parents, potentially other siblings as well. Palliative care is important in some areas of rare disease. And if it is relevant to the patient, we need to make sure that they're getting early referral into palliative care so that they can manage any pain and improve quality of life. Primary care assessment is essential in rare disease. And this is another, I guess, a health system navigation challenge for people with rare disease, is finding that GP that is supportive, that understands their condition, and understands what referrals need to be made for that patient. So we talk a lot to patients about, do you have a good GP? What's your care plan with your GP? And if they don't, sometimes we can help them find a GP that has a bit more understanding of rare disease, and also give them the tools, particularly in the Australian context, if they're not on NDIS, getting mental health care plans, chronic disease care plans, and really making the best out of the health system. There's also a really important education component, so helping the patients take the information to the GP to educate the GP about their condition, as well is a really important role for, unfortunately, for a lot of patients and families with rare disease. You have to become an educator just by the nature of the condition. Pain management is something across the health system that's often neglected. So in telehealth, we always make sure we ask about pain and whether, if patients have pain, are they under management, and making sure for early referrals into pain management care. A lot of patients are okay, they don't have chronic pain, but it's an important question to ask. Then probably the most important in health system navigation for people with rare disease is an MDT assessment. So when we do an assessment with a patient, and their family, will go through everything that is troubling them, or their symptoms, or the way that they're presenting. And then we say, okay, for each of these, what MDT allied health specialists do you need to be referred to? So making sure that patients have access to the right specialists, allied health, making sure they've got the allied health team together, whether it's physio, OT, speech, whatever it might be, and then helping them find those allied health and taking it back to their treating clinician for the appropriate referrals. So all of this happens in about 45 minutes to an hour. So it's an incredible value to the patients, a relatively low cost to the health system. Within the program, one of the great things we've been able to do is identify all of the different nurse-led interventions that can happen in telehealth, where the nurse is within a patient organisation. So this is a really big step forward for community-based care, to be able to really say, this is what we can do, and it sets those boundaries and limits for the nurse as well, so that we're all working within a safe scope of practice. So what I'm going to do here is just a quick case presentation, and this is fairly representative of most of the patients that come through our telehealth clinic. So it's usually a parent. We primarily work in the paediatric space, although it's not always. So 99% of the time it's the mother on the call. I don't think I've ever had it where it's only the father. It's usually the mother or the parents together. So this was a young girl. They lived in a metropolitan area, welfare dependent family with history of thyroid disease. The primary diagnosis of the child was a rare genetic mutation, and I haven't put it up here because it's quite identifying. It was ultra rare. But that presentation came through with transverse limb defects, increased ocular pressure, wet pattern on skin, and localized absence of hair. But then a number of comorbidities around that as well. And in rare disease space, this is incredibly common to have really complex comorbidities that need to be managed. ASD, GGD, ADHD are all very common in the patients that come through the clinic. This particular little child had vascular inefficiencies as well, and hypertonia, which is also quite common. So as you can see, there's a lot of things for parents to manage to link into allied health. And that's really a challenge for rare disease in terms of health system navigation. So the reason this family came was actually because of recurrent pain episodes and not really knowing how to proceed within the health system. So from our nursing side, we did a full review of diagnostic tests to see what had happened and see what else needed to be done. Full medical history, had a discussion about the genetic mutation, differences between clinical geneticists and genetic counsellors. So the majority of people that come through the clinic won't have had a genetic counsellor and access to it. As another shortage in the Australian health system is access to genetic counselling. So there's really, for health professionals, we're having to triage who does and doesn't get through to genetic counselling just because of the caseload that's coming through. We reviewed their current care team, documented a summary plan for them. One of the things missing in this child's care team was a paediatric physiotherapist. They were getting ready to drop that off because it was too hard. They couldn't find anyone. So we called around the local physios to make sure there was someone that had worked with paediatric patients and had some experience with rare disease. Incredibly important to get referrals to allied health that have experience in rare disease and not send people through to people that, health professionals that haven't had that experience. We made connections for them with the pain team, the gastro team at the local hospital, and developed a list of prompt questions so that they could drive the questions with the specialists so that they got the answers that they needed. A prompt list for the vascular team as well, just around some of the vascular inefficiencies, which were important for the ophthalmologic testing annually, which went under general anaesthetic. And then tools for monitoring paediatric pain, which we also developed so that the teacher of the child could monitor that pain as well because it was sporadic. developed a glossary of terms for the family so they could understand some of the terminology, and also discussed a chronic health care plan with the mother. So you can see it's quite holistic and a lot happens within that 1 hour or so. Selected this case because it's actually quite representative of most of the cases that come through in rare disease. They're complex and they're difficult, and they include the whole family, not just the patient themselves. Multiple specialists involved as well. But if the patient hadn't come, they probably wouldn't have known about the ability to ask for a pain review, wouldn't have known about genetic counselling and the limitations there, or how to access genetic counselling, wouldn't have understood those implications of vascular limitations, particularly as the general anaesthetic was used for the annual ophthalmology exam. Physio would have dropped off for sure. And what we're able to do is centre their ongoing care plan with their paediatrician. So again, not creating a dependency on our service, but helping them make the best use of the health system. So for this program, it's one that we have developed that can benefit other rare disease areas as well. And this is something that will be going forward for government support next year, where rare disease groups can join a joint submission to apply for funding for their own telehealth nurse that's specific to their disease. So we've really been able to quantify the time spent on patients for case management, test what level of nurse is needed in this setting. We've got information around the costs, and there's a cost saving element that we've been able to demonstrate. Got a minimal data set, which is really important for ongoing evaluation, and just showing what value patient organisations can bring to the health system. And we've really identified those nurse-led interventions, removed geographic boundaries through telehealth, and identified those most common roadblocks for patients. So that is it for the presentation. I can stop here and take any questions.
There are, thank you very much for that. It was actually quite informative, and knowing, and it's also very encouraging that there is actually something out there that can help that newly diagnosed parent as to what pathways to take. There are some questions in the chat box. Are you happy to answer them?
Yeah. How can we access the information?
We have got how can we access the information toolkit to help in those conversations with doctors who don't have a lot of exposure with dealing with a particular rare disease?
Yeah, so that's something I do. So I work across particularly the genetic mutations, so duplications, deletions. So every single patient that comes through, I have to develop a new information sheet for, essentially. So I'm happy for people to get in touch with me, and I can share examples. The way that we do it is we develop an information sheet about this is what the condition is, and then underneath it, almost a tick box thing that we go through the patients with that essentially says, but this is how it affects me. So not every patient will present the same way. So it's kind of giving the generalized information and then more information that's specific to the patient.
That's actually good that it's not a one size fits all, that you actually do go in there and look at the individual cases and then go from there on how to best care for them.
Yeah, that's especially great in rare disease, because everyone's presenting a bit differently. And, you know, we work by case studies in terms of how we're collecting information.
Yeah, no, that's actually quite good, because it's not always done within, I suppose, in this setting that, you know, you have a rare disease, and just because it is that rare disease, I don't think they realise that each individual patient is actually affected differently by the symptoms. So it's good to know that when you are assessing, it is actually done on an individual basis. There's also another question in here. Okay. Is telehealth accessible to patients and carers around Australia?
So the big answer to that is yes. So that it's available in lots of different ways. There's lots of telehealth at the moment through general practice, through specialists, through all sorts of things, which is, I guess, one of the positives of pandemics is more access to telehealth. For our service, absolutely. If you would like to set up a telehealth for your nurse, you can join the joint submission. In the meantime, if you want some help, just get in touch and we can see what's possible. But yeah, telehealth is really accessible in Australia. Still difficult in remote and rural areas with connectivity.
I was actually wondering about that, whether you do reach out to those people that do live in regional areas around Australia. And as you can appreciate, we are a large country and very spaced out in some of the states, especially, or for me, coming from Queensland, especially so. We are a large piece of land, a large piece of state, and we have regional centres that are quite far. So I was wondering how that would work with those kind of patients, especially with the COVID in the mix at the moment, listening to a lot of patients that do rely on healthcare within the hospital systems that are closer to the city. So their travelling time in getting to those places can be quite difficult and encompassing sometimes. So good to know.
No, it's a really important service for regional and rural patients, helping them link into specialists in the metropolitan centres that have the more expertise, but then connecting back to more locally for either treatment or ongoing management, so that they're not having to travel 300 kilometres to, to the centres is incredibly important. And tapping into telehealth for them as well for things like mental health care plans and all of those things is really been fantastic.
So does that apply to you when we were talking about regional centres as well? I suppose that we're looking at those people that live in border towns, that live, in and around those areas, and then having to find healthcare in a different state. Do you guys cater for that also?
Yeah, that's an incredibly tricky, complex kind of patient living on a border. And crossing.
A lot, especially with COVID being in place, there's a lot of people that require that kind of help that can't get into a state because of, of the blocked borders. But I'm supposing that before COVID, that situation would still occur where they're living in say northern New South Wales and are needing to come into southern Queensland to get healthcare that is not provided in the area they're living. So
yeah, no, that definitely happens. And although most patients are willing to travel, even if you're in Queensland and your specialist's in Melbourne, that happens quite a lot anyway. So that's where the coordination part comes in. If someone is newly diagnosed and they're in Queensland, needing to go to Melbourne, it's linking them up with the right specialists. If you're lucky, there's a nurse coordinator at the centre as well that you can link them into, and just getting them that referral pathway is a big part of it. It's not impossible, it just becomes a bit tricky, and you still want to leave as many services local as possible because these are usually really busy families with lots of appointments. So you want to centre their care where it's easiest for them to navigate and help them set up. So if all their specialists are in another state, making sure that all their appointments are set up around the same time so that they're not ping-ponging back and forth. So some of it's common sense. It's nothing to do with nursing. It's just helping patients organise a really tricky situation.
Yeah, I guess that's also knowing, where those healthcare centres are, where they can actually go to those specialist appointments within their region. So they're not having to travel 2,000 kilometres to get care or go to appointments every single time because of the rarity of their condition. So it's good to know, and it's actually encouraging to know that the focus is on, okay, well, let's, we can go anywhere in Australia if we've got that particular specialist in that field, and so that is actually catered for and not just reliant within the kilometres of your own state. So it's good to know, very encouraging. Yeah. Oh, okay. Has anyone got any further questions? Agnes, do you have something you'd like to ask Kate?
No, not really. I just wanted to say hi. I know it's, I don't even know what time it is in Geneva, Kate. So thank you so much for joining us for another important, informative session for us. We always want to learn more in terms of understanding the system for us. And this is very important. But one thing I just wanted to quickly ask, I know you are also do a lot of work in research. hence your organization. And we have discussed this before. We will come back to discussing like how can we be part of the research, because there's not much research in terms of sickle cell disease in Australia. So what sort of area of research are you doing or are you planning to do in future?
Yeah, so our research program, it's called Personal Experience, Expectations, Knowledge. So we talk to patients and families around their experience in the health system. We use a single protocol so that we can compare and contrast against disease areas to understand, you know, where a disease area sits, so to speak. And it's information that can be used for evidence, for advocacy, for health system planning, to support health technology assessment, all sorts of things. It's a really holistic protocol. So unfortunately, we're in the same boat as everyone, where we need to go and find funding for research. So the second we can find some funding for sickle cell, we'll be on it, talking to patients and families with sickle cell. But it's really a great tool that you can use for years and years to come. But please get in touch again, and we can see what's open at the moment and get some things moving.
As always, thank you so much. Thank you so much for joining us. Yeah. Over to you.
Thanks, Agnes, and well done on the conference.
Thanks very much for joining us, Kate. It's really been a pleasure getting to
Thanks.
know and encouraging that this work's been done for not just our condition, but also many other conditions within and around Australia. We're a very lucky country. Thank you.
Yeah.